Hello. Hello.
How are you?
Okay, how are you?
Well, you know, I am outside my house, so that's important.
I agree.
You
Totally
know,
agree.
is it only you and me?
For now, it's just you and me.
But you're recording it, so you can show it to my wife, and I go into deep trouble. And I tell you that
I
um,
don't think so.
it was very good that I was at work for the pandemic, and my wife and I, it would have been, it was way too much. We would have really lost it and chopped.
I know how it feels. Exactly. I have to get everybody on the screen.
Well, you share yours, which is excellent because you have my talk, so that's perfect because then I can just be fantastic.
Yeah, I do.
Okay, can I rush out to get a quick water? Is that okay?
Yeah,
And
yeah,
I come
sure.
right back.
Yeah, I'll be
I
here.
put my
I'll be here.
And thanks for putting me first or second or something because I got that's nice of you because I can actually have fun at dinner.
No problem.
I was it was operating till now from like 7:30 till now, so kind of
Wow.
yeah, long day. We have
Ashley's going to be back and forth because she has a case soon also. So
yeah.
she'll go back and forth. Okay.
All right, see you in a sec.
No problem. Hey.
Hey.
I couldn't find anyone now. I go, where is everybody?
What?
Hi, Victor. That's not Victor. Okay.
I was looking at the screen because I turned around to close the door. I'm going, whose screen is that? And then I realized you were sharing it.
Yeah, I have to share it.
Oh, see, it's almost the end of the day.
Oh, thank God. Okay.
Okay. All right. Here we go. Just recorded a. Looks like you're sharing your screen, Val, which is
I
great.
am.
And then will I be able to share my screen to show the talk that we put together?
Nancy Kondo would be the expert in this. I wouldn't. Nancy?
So you have to go where it says share screen. I won't be able to do that because I'm not in there as a host. And you have to click enable all participants,
Yes, that sounds right.
right?
Yeah.
Do you see that, Val?
Where are we going?
Down to the bottom where it says share screen.
Where it says share
Screen?
screen, and then if you,
You
I think
share.
right, is it, you have a PC or Mac? If you right click, I
PC.
think on that, if you hit it, then there
Yeah.
should be an option to enable all participants.
Yeah.
Okay.
Okay,
Got it?
great. So let me just try to share my screen now, okay, for a second. Okay, so if you stop sharing your screen,
Okay.
okay, and then I'm going to share my screen. Oh, yeah. Host has disabled attendee screen sharing.
Okay, I'll put, okay,
So
try again.
try it again.
Yeah.
Okay. There, that looks good. And yeah, so here we are. So you can see that now. So that's
Yeah.
perfect. So what I'm going to do now is I'm going to stop screen share. And we'll go to gallery view, and then you'll be able to share your screen with the kind of the agenda, and then we'll just go along there. Okay. Hi, Victor. Thanks for joining.
Hi, Dr. Finning, how are you?
I'm good. I'm good. Thank you for thanks for participating. Appreciate it. I'm sure you have many demands on your time, but it's greatly appreciated. And I understand Mingyao Lu has asked you to speak on behalf of IMS, which I think is cool.
Yeah, I'll do a brief introduction, but he also asked me to showcase our lab, so I'll try to do that as well.
Okay. Good. So we'll just wait a few more minutes. So good evening, everyone. I'm Michael Failings, the Vice Chair of Research in the Department of Surgery, and welcome to this evening's session, which is a combined session. It's an orientation session to the Surgeon Scientist Training Program for PGY1 and PGY2 residents, and it's also a meet and greet for the incoming Surgeon Scientist trainees. So this is a first for us to do this virtually. Looks like we're starting to get some participants coming. We have 27 people. Cool. Okay. I know that some of the faculty have some other clinical responsibilities and might be joining us a little bit later, but I think that most, if not all, of the faculty will be participating. So just while we're kind of assembling, and I'll just wait a couple of more minutes, maybe start at 5:05. We'll do a quick round of introductions, and Val will share her screen in a moment just to kind of show the show the agenda. And when people are presenting their talks, if people could kindly mute their microphones, and then also to just kind of blank the camera. The chat line will be open, so if you have questions as they're arising during the course of the events, I'll be monitoring the chat line, and we'll have discussions at the end, and we'll try to keep this kind of as informal and as informative as possible. Okay, so we're up to 32 participants. Okay, great. Val, perhaps if you could kindly share your screen and just pull up the agenda.
It's not shared anymore?
Yeah, so if you go to share screen, and if you pull up the agenda.
I thought I had.
Otherwise, what I'll do is, just give me a minute here. I will see if I should have this as well. So just a moment then. Yeah, so why don't I go ahead and do that, Val, then? Okay, so let me just have a look here for a second. See if I can, here we go. Great.
Okay, do you see it?
Whoops, darn it. Oh, sorry. Are you trying to share your screen right now, Val?
Yeah.
Okay. I don't see your screen.
Oh, it says you are sharing the screen.
Oh, let me stop sharing. And then there we go. We got yours. Okay. We're working out the glitches here. Okay. So perhaps if you just expand your screen. So welcome everybody. I want to thank Val Cabral for helping to organize this evening's event. And we've got the agenda kind of laid out here. I want to thank Jim Rutka, the chair of our department, for the support of the department. Jim, I think you're there. Let me just go to gallery view. So we have a Jim, and we have several faculty members. So I might just ask everyone who is speaking to keep their remarks very brief. Slides are optional, but if everyone could just kind of speak no more than about 5 minutes, that would be perfect, so that we can then kind of get to the question and answer, and then we can make all of the slides available afterwards for all of the participants. And so we're going to give an overview of the Surgeon Scientist Training Program, and then we'll talk about kind of the different topics which we think will be of relevance. So we'll be talking about translational research, and then we have an overview of 2 of the graduate departments where many of our surgeon scientist trainees study, Institute of Medical Science and the Institute of Biomedical Engineering. We also have an overview of the IHPME program for those studying clinical epidemiology. And then we have a variety of topics ranging from translational research, various clinical research topics, and kind of various basic science topics. We've invited some of our recent SSTP graduates to come, and then some our current SSTP research committee representatives, and we'll have a question and answer session. And at the conclusion of the evening, I thought I would share a few ideas about potentially having a follow-up session to this that would be exclusively kind of an informal question and answer session. So Val, if you could kindly stop sharing your screen, and then I will pull up my PowerPoint.
Okay.
Great, thank you. Okay, so welcome everyone. So the Surgeon Scientist Training Program is one of the crown jewels in the Department of Surgery. And the impact in research in our department by the faculty and the trainees is really one of the great things that sets our department from other faculties and other departments of surgery. And it's really, I think, one of the cool things that's offered to our trainees. This is our research committee. I wanted to again thank Val Cabral, who is our research program manager, who kind of is the glue that keeps everything together. And Val is very proactive in terms of helping the surgeon scientist trainees. And I wanted to, in particular, acknowledge our two resident members, so Lorene Hatcham and Douglas Chung. And our resident members are really key in terms of advocating for and really helping us to ensure that we try to meet the needs of the resident trainees. And we have a very dynamic input from other members of the committee, and they're really a great group to work with. So the purpose of the Surgeon Scientist Training Program is to provide a formal training opportunity in graduate research for surgical residents. And the essence of this is that this must be a thesis-based graduate program. So there are some kind of 1- and 2-year professional master's courses, which certainly have their value, but that does not fall under the program of the Surgeon Scientist Training Program. The Department of Surgery provides partial salary support, but I'll show you in one of the concluding slides kind of the financial challenges related to the program. So we have a limit for 2 years for those in a Master of Science program, and that is almost always the amount of time in which a master's can be completed, and then 4 years for those pursuing a PhD. All trainees accepted to the Surgeon Science Training Program must apply to and be accepted by the School of Graduate Studies and accepted into a program leading to either a thesis-based master's or a PhD degree. And all of the supervisors must hold an appointment in the School of Graduate Studies. And so there's a few steps in terms of the application a process. And so you need to have a go-ahead from your division to proceed. So this means that you need to have spoken to and have written support from the chair and the residency program director. You should have identified a supervisor, and discussions around the funding support need to be in place. A preliminary concept of the project should be identified, and then the preferred graduate department should be identified. So this slide just kind of shows the the impact in terms of numbers of the surgeon scientist training program. And since 1983, well over 400 trainees have gone through the program, with the majority receiving either a master's degree or a PhD degree. And this shows the growth in the surgeon scientist training program over the years. And pretty much since about 2016, we have kind of hovered between 45 to 50 surgeon scientist trainees in the program. And that's around what we feel is the correct number. And so currently this is our current cohort with 48 applicants, and roughly half doing master's degrees and half doing PhDs. And these are some photographs of the residents who are currently in the surgeon scientist training program. And it's really a terrific group of students. I just put this a slide up just to kind of give you an idea of the financials. So this is a substantial program. This is about a $3.5 million program. And the supervisor contributions amount to just under half a million. There is some support that we get from the clinician investigator program, and a number of the divisions, though not all, provide a year of support through the Ministry of Health. This big one here is the contribution from the Department of Surgery. So it's just under $1 million. And then the rest of this are awards to the students. And so the Students Fellowship Awards account for over half of the funding support. And so this is an important component of your success and of the success of the program. So on that note, I'm going to stop sharing the screen, and I'll call on Jim Rucka, our department chair, to say a few words.
Yeah, thanks, Michael. I'll be very brief in the interest of time and acknowledging all the other speakers. But thank you, Michael, and thank Val for organizing this evening. I've been chair now for 9 years, another year to go for me. But over the last 9 years, it's been a real privilege and a pleasure to watch the growth and see the accomplishments of all of you that are in the SSTP. It is, as Michael said, a highly supported program in the Department of Surgery, and one that we're all very proud of. And we look forward to your many accomplishments as you enter the program and as you course your way through the program. It is a program that has some boundaries around it now, and I think those had to be put in place because of the, as you saw from Michael's slides, the cost of the program. But we are absolutely dedicated to supporting this program in the Department of Surgery, and I think we will continue to be for many, many years to come. So I wish you all good luck as you are choosing your research ventures, your programs, your supervisors, and if there's anything that we can do to help you along your journey in the research laboratories, don't hesitate to let us know. I know it was a major reason why you selected the University of Toronto was because of the opportunities to do research, and we're fully behind you with the support that we provide. So thanks, Michael.
Thank you, thank you, Jim. Albert, I might go out of order slightly and introduce Andras Kapush. And Dr. Kapush is the Associate Vice Chair of Research. He's an MD PhD, working mainly in basic science. And Andras's role is in particular to advocate for the many faculty in the Department of Surgery who are full-time scientists and are not doing a clinical work, but Andras brings many different perspectives and strengths. Andras, a few words from you. I think you're muted.
Unmute, yeah, Mark.
Yeah, I'm muting myself. Thank you very much, Michael. I apologize because actually, as of today, the SandMike's email system changed to a new, very secure system, so secure that I'm not able to reach my email. And I have some slides here, and therefore I'm asking whether it would be possible that I can share my screen.
Yeah.
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 Because
Yes, you should be able to.
Yeah, because I put multiple sharing.
Okay, so in that case, I'm trying to do that, and I would. So
Okay.
hopefully it's visible. Yes.
Yeah.
Okay, thank you very much. So I also would like to then welcome everybody, and just really a few words. And as Michael pointed out, I would like to speak a little bit about the diversity and scientific colorfulness of the department, really. So obviously, the goal is, as you all know, is to provide the surgical residents with a real enriching training experience that will enable them to do academic surgery, and so that career can be really based on these couple of years that is spent in the program. And basically, I think the most important thing really to be able to be successful in this program is what I call a fire in your belly, which is a true interest in research. And I think I would say that's the #1 requirement that should determine whether one is coming into the program or not. If you're really interested in exploring, then it's your place. And the research topic and question, as Michael also mentioned, is an important thing, but of course it can be selected on the road, and you can shop around a little bit, and you can shop around from an unbelievable wealth, and that is really fantastic at the Department of Surgery. Namely, there is a cohort of basic researchers and a cohort of basic research areas which encompasses cellular and molecular biology and pathology and pathophysiology and neuroscience and bioengineering and material sciences, really, just to tell you a few. But in addition to that, there is very strong clinical research, a very strong clinical epidemiology research. There is ongoing research in medical education, bioethics, health services, what have you. So that determines a little bit, of course, what you, where you go and what your interest is. That determines the path, which graduate school you would like to belong to, because the fact is that the Department of Surgery as such is not a disease-granting entity, so you have to belong to a graduate school, and that's a technical detail, but really Val is the master of that. You really have to be aware of the different rules and the deadlines of the particular graduate school and your supervisor's affiliations, where you want to belong to or should belong to, depending on the topic you select. So this is a little bit of a homework to do, but it is worth doing because there is such a wealth of topics and such a wealth of, in fact, different departments who you can belong to. And you also don't have to choose, for that matter. It's a wonderful freedom in the program. Necessarily anybody who is appointed at the Department of Surgery, either as a clinician or a clinician scientist or a basic scientist, practically anybody can be a supervisor. But you have to have acceptance to a thesis-based program through one of the graduate schools. So, you know, who are we? And so I like to call ourselves a wonderfully heterogeneous group, because really it's a very, very diverse group of people. There's a total research cohort approximately of 232 scientists. Those are just the ones that belong to the Department of Surgery. appointed at the Department of Surgery together with clinician scientists, approximately 52 scientists, independent scientists whose number one job is research and with no clinical application. So that's an unbelievable cohort. I believe it is the highest among all the departments at the University of Toronto. And that's a tradition that built over the years, and we can really be proud of that. Here are 34 disciplines that I tried to list in more or less alphabetical order in order for you to select from, which really goes from basic anatomy, because for that matter, cell biology and anatomy, the Department of Cell Biology and Anatomy also belongs to the Department of Surgery, kind of a sister department. It goes to transplantation. And again, from bioethics to biomechanics to cancer biology to sociology to engineering, you can have all this still within department. We have experts in all these areas. This shows a little bit of my mania, if you will. There was a drop in the willingness of new surgeon scientist trainees to engage in basic science programs, bench science programs, that is, and that was partially because there is a sense that it cannot be done and cannot be well done, and it's incompatible with your future, and it is difficult enough to be a really good surgeon, let alone to have a lab. Well, I don't doubt the difficulties here and the challenges, but it's extremely rewarding. And all what I can say is that this department is full of excellent clinician scientists who publish very high quality basic research and are leaders of many fields, be it cancer biology or neuroscience. So it's far from being impossible. And I like to dissuade being, overly cautious. If you feel that you're interested in pursuing some basic science, push the statistics a little upward where it used to be. And that's just my personal advice. Finally, I would like to just highlight a couple of excellent basic scientists and call your attention to the fact that you can choose them as well. So it doesn't have to be practicing surgeon who your supervisor is going to be. Of course, that is totally possible, but just a very selective and, if you will, ad hoc highlight to see the diversity of disciplines that also world famous or very, very renowned scientists at the department. This is Karen Davis here. She is a brain imaging expert working in the area of pain sensation and psychological and physiological perception of pain. She has a wonderful lab and excellent publication. This is Mohit Kapoor, who is a scientist at the Western Institute, Research Institute, who knows all about osteoarthritis and conducts both mega clinical trials and very strong basic research in the area. This is our Kerry Wine, who is again an unbelievably productive scientist, and she is her area is orthopedic biomechanics, and she knows all about bones and bone fractures and metastasis in the bone and the engineering aspect of that, as well as clinically relevant therapeutic modalities and the design of minimally invasive technologies for bone injuries and reconstruction. This is another superstar here, Ranky Lee, who is a hard guy and basically a really, really important workshop his lab is in terms of cell transplantation and finding new, predominantly cardiovascular applications for cell transplantation in terms of myocardial infarction treatment, but also general bioengineering and angiogenesis studies. This is Sydney Morshead. She is a scientist at the Department of Anatomy and Cell Biology, which I said is kind of the sister institution of the Department of Surgery, and she is a very well-known stem cell lineage and stroke regeneration expert whose lab has also contributed a lot in terms of brain injury. I am sorry not to speak about the equally excellent clinician scientists, for example, in the same area, but I believe you are more familiar with that. So I have chosen this path just to highlight a few people. This is a colleague of mine, an excellent cell biologist who practically looks at membranes and lipids, and his primary interest is lipid signaling, but that of course feeds into immunology big time in terms of phagocytosis and host pathogen interactions. So this is just, to give you the taste, what's on the table here, and to opsonize a little bit your willingness and interest in doing basic research. And of course, should you need any advice, I am always available. Technical details, Val is the major expert, but you can reach me when my email is working, and hopefully it will soon at the email below. And I'm very happy to help, even with advice in terms of placement if you need any further information. Thank you very much.
Thank you, Andres. Appreciate your excellent comments. So perhaps we'll go over to Albert Yee, who is a clinician scientist and chairs the research program in the Division of Orthopedics.
So thanks so much, Michael. I hope everyone can hear me well, and good evening. I think it's a great opportunity to get a bit of an update in terms of the opportunities of the Surgeon Scientist Training Program. And so, as Michael's mentioned, I sort of help facilitate some of the activities within orthopedics, and I've got a fairly large program with about 60 faculty, and at any one point, typically around 50 odd clinical fellows and about 40 to 50 orthopedic residents spread out around the city. And a lot of what we do in orthopedics sort of focuses on clinical outcomes. We were sort of involved with the competency-based curriculum pilot, before sort of CBD, and have a lot of interest in education research as well as biomedical engineering, as Andreas has sort of mentioned, in orthopedics, biomechanics, computational modeling, translational research, including some of the omics relating to arthritis. And I guess this is where I'll show my age a little bit. I myself am an alum from the SSTP program, started graduating back in 1996, so it's been some time. And I guess I'll probably just spend the rest of my couple of minutes articulating why I feel sort of the pros and opportunities of the program that certainly vastly outweigh the cons, and really I think sort of looking at it, the main consideration I think really for many at your stage in training, recognizing all the education that you've been involved with to date is really the additional time. And I hope to at least highlight why I feel that this additional investment in time can actually pay dividends, and certainly that's been my personal experience, and I think a tremendous opportunity. So I think some of the advantages, as Andre sort of mentioned, you really get to become a content expert in your particular field. Actually, by the end of the studies, you'll be actually educating your supervisor and your thesis committee. Certainly, I felt that the experience certainly provided an opportunity for me to be able to more critically appraise the literature, and basically place the literature into context during my training. Not to use an orthopedic term, but to really sort of be in courses that sort of bones up on your statistics, your methodological approaches, that it really gives you a better sense of how to read the literature and to interpret it. And certainly with my supervisors, Earl Bogosh in particular, I certainly learned how to write better, really focusing on articulating really what I mean, really not overstating findings, but really placing the scientific findings into context, and really what future directions or questions really do your findings motivate. And I certainly got the appreciation of really what goes into a research project and what's involved in really taking a project through to fruition into publication and awards. And particularly, I think that resonated true in clinical trials. I really didn't realize the logistics involved with conducting a trial and the infrastructure required, interactions with REB, et cetera. And so, without that experience, certainly, you sort of read many RCTs and clinical outcome studies out there, but really, providing that insights in terms of understanding what's involved and obviously how to place the results of the trials into context for how you manage your own sort of patients. It's been a tremendous opportunity, I think, to develop lifelong mentors, both clinically as well as in research. And I think ultimately that can certainly help with fellowship positions and jobs at the end. And I know many graduates that feel the same and have their opportunities and doors, additional doors really open because of that experience. And when you think about the next stage of your training, recognizing that the vast majority of you now will undergo a fellowship following your training, 90, 95% plus, you really want to, enroll in a fellowship that's really a top tier fellowship. There are fellowships and there are fellowships, and you really want to, have that focused, advanced experience that will give you those sort of additional competencies to really sort of hone your skills. And generally speaking, many of these high top tier fellowships are at academic centers, with folks that have very strong reputations. And so coming out of a SSTP and, sort of being compared to other trainees around the country and internationally, your CV, your experiences, your letter of support, I think will speak strides in terms of being competitive for some of these fellowships. So I think, in terms of, how SSTP has been pivotal to sort of where I have sort of ended up here today. I really didn't, personally, I did not have a graduate degree when I went into medical school, so I really wasn't sure what research was all about. I was just ecstatic knowing that I was going to become a surgeon and had the opportunity to decide what type of surgery, and ultimately ended up in a career in orthopedics and in spine surgery specifically. I knew all along that I really would enjoy, and I did enjoy continue to enjoy the teaching environment and really interacting with bright young individuals, many of folks who are brighter than I am. And I think one of the things I certainly realize in my role right now as an academic orthopedic surgeon is really the ability of the clinical background to contribute towards the research mandate and really bridging that bench to clinic, and the value that I actually bring to the table to individuals that are full-time scientists, as well as to many of the young, bright, non-clinician graduate students and postdocs that are eager to learn from us in terms of the clinical relevance and the clinical opportunities. And in my role now, sort of leading, various programs and division activity within orthopedics at my hospital and some of the work at the university, really looking for opportunities for strategic recruitment of individuals based on that model. I personally think that, links the clinician scientist with the full-time scientist, and looking really for synergies in the same area to really more quickly drive forward the translational and research mandate. In terms of, I guess, the cons, I talked about the additional time. I think there's certainly much more time that you'll have for reading around your various topics. I think the graduate schedule is slightly, I might suggest, is slightly different than residency life. But many folks going through that program do and are able to sort of balance work and life aspects. I sort of got married, during my time in the SSTP, and I know many others. I take this as an opportunity to organize and plan key life events. Technical skills, I think if anything, it's just a transient effect that comes back fairly quickly when you come back to the clinical arena. It also depends on what type of research that you're doing. I was in a translational lab working on preclinical surgical models of arthritis of the hip, and I was actually, involved with surgeries on canines and hip replacements, and so actually, I found that I was able to keep up my technical skills, and if anything, I gained additional expertise and some experience operating in different species, which actually has lended itself quite well in terms of some of the work that I do currently. So I guess I may sort of close sort of at that stage. I think the opportunities in research are endless. I think, for those of you thinking about it, what are the most important and sort of pressing questions? And, I think, even just looking at where we are today in the midst of a pandemic and on a Zoom call, I mean, I think just thinking about the far-reaching impacts of COVID and, on research, on clinical trials, how we functionally operate, in our clinics, virtual care, those that have interest in health systems management and our systems, what are the vulnerabilities, what are the opportunities for process improvement, quality improvement, how do we train? Some folks have had less exposure hands-on during the ramp down sort of periods, and what are the opportunities in surgical education? So thank you so much, Michael. I'd be happy, looking forward to participating in the discussions that follows and answer questions that individuals may have.
Sure. Thank you, Albert, for sharing your perspectives. And I think many of the faculty that you'll hear tonight are actually graduates of the Surgeon Scientist Training Program, as well. So that's cool, and certainly Albert has benefited from this in his career. So Professor Yee kind of touched on this concept of kind of bench to bedside, if you will, and kind of the unique role that the surgeon scientist might play in translational research. And a few years ago, to recognize the importance of translational research, we set up a special committee in the Department of Surgery to try to drive translational research efforts. And Professor Mark Jeschke leads that committee. So Mark, please, your remarks.
Yeah, thank you. Thank you, Dr. Fillings, and thank you for the opportunity to speak and maybe attract some motion and energy for translation research. And as you all heard, translation research was mentioned many times by Dr. Kappers and Dr. Radka, as well as Dr. Yee. And we believe that surgeons, in particular the department, had the vision to be at the forefront and establish this committee. We think that surgeons are heavily involved in translational research, and I would put this out to you that the function for this translational research committee and that you can tap into is twofold. One is to get advice if you are involved in a translational project and you got stuck in terms of patenting or licensing or advanced innovation, we're happy to consult and work with you. Or if you want to test some basic science aspect in terms of a clinical trial, again, we can link you. The other aspect surely is that we would like to raise your interest to join one of our one of the mentors that are serving in our committee, and that you take on a translation project. And translation project in general, and I'm hoping Val can share the slides later. I'm not going to share right now slides, but I put some together determining what is exactly how do we conduct translational research and what's the outcomes. And as you can imagine, there are various challenges and fascinating challenges, how to discover a basic science aspect and then take it all the way to clinical trials and larger clinical trials, and then conduct population-based studies. And we as a committee are here not only to help you, but again, also to make sure you succeed, which is one of the wealth what Dr. Kappers was saying. And we have a very vibrant committees. We have very senior members reaching from basic scientists to clinical trialists, to epidemiologists, to molecular biologists. And again, I think the fascination of surgeons is not only that we are doing these trials, we also have access to tissue. And I think that this translational research committee is very active, and it has a tremendous opportunity to help you all to succeed in your projects, and was happy to do so. And if you need to contact us, we are on the webpage, as well as Val can connect you with one of our committee members, and we will share the slides afterwards where you can dig into deeper information if you wish, and that that's actually what I had in mind, to be brief and just outline the tremendous opportunity that the department offers, particularly in translation research. Thank you for your attention and your time.
Thank you, Mark. And just a shout out as well, on September 28th, there'll be a lovely symposium on translational research. Did you want to just briefly mention that? And then we'll be, I think, trying to distribute that information quite widely.
Yes, thank you to bring this up. So we usually have once a year a translation research symposium, and this year was actually very exciting because we had a hands-on course and classes that really take some discovery all the way to commercialization. Unfortunately, we couldn't hold it. So we will have 3 webinars as you wish, and the first one will be September 28th. We will have 3 of our own surgeon scientists who are conducting translation research, and I can tell you these talks, we listened to them at Galley and we heard them afterwards, they're phenomenal. And then we pair this with a invited speaker, and Dr. Santerre is a bioengineer, tissue engineer. He's going to be our invited speaker. He has numerous patents. He took successfully from idea to application, and so that is September 28th. We will have another one in November, and then be in February, and then we hope we have our day again next year, early around the Galley Day. But I'm hoping you all can join, and we will send out some further information. And I'm really happy if you have any questions or anything concerning translation research, please reach out, and we will connect you and make sure you'll be taken care of. Thank you.
That's great. Thank you very much. Okay, so let's shift gears, and Dr. Victor Yang has been asked by Dr. Mingyao Lu, the director of the Institute of Medical Science, to talk a bit about the IMS program. So Victor, interested in hearing your remarks.
Thank you, Dr. Failing. So I was asked to give a quick overview of IMS, and also to showcase some of the research that happening in my lab that's part of IMS as well. So I'll try to be brief and then get through this for everyone. So interesting, before Mingyao asked me to do this, I actually didn't know that we rank really well in the world. And so university-wise, we rank 18th overall, but the clinical medicine, we rank 4th in the world, and the surgery also rank 4th in the world as well. So clearly all the trainees choosing to University of Toronto and surgery and has a very good reason to do so. And within the IMS, I want to point out that, in fact, the surgeon scientist training program has a large representation in IMS. About 40% of the SSTP trainees are actually registered in IMS. So this goes on to see the tradition of excellence in IMS and the SSTP program here. There are a large number of graduate faculty in IMS, and also, a lot of them are actually surgeon scientist trainee alumni or CIP alumni as well, and almost half of the professors are actually full professors among the faculty. And here you can have a glimpse of how the distribution of the clinical faculty, and the surgery is a very large portion within the IMS clinical faculty. Students wise, also there are a lot of them here, as I alluded to earlier. So there are about 200 doctoral students, and then 230 master students within MS, and there are professional master students and clinician scientists as well. So there's a lot of impact being achieved by the students, and I'm going to showcase some of that happened in my lab just a little later. So you may think about, why you want to choose MS, and then a lot of our faculty members are cross-appointed with many different collaborative programs within their university, and therefore we do expect very collaborative interdisciplinary research. And as a pearl of the wise advisor to the PGY 1s and PGY 2s here is really want to make sure understand that the supervisor and the lab environment you'll be in is probably the single most important factor, and that the institution which you can register in probably comes as a secondary importance in terms of how you can make your decision. So within surgery, part of the IMS, there are many, many research teams, and here are just a few examples of them, and then we all sort of congregate into our groups and then try to make impacts. So you can seek us out and then find out where your interests are, and then it may or may not need to be linked to your actual clinical interests, because each of these labs may work on very, very different things depending on the research topic. So just want to give you a quick showcase of what happens in my lab. And then again, my lab collaborates with many of the faculty members in MS and out of MS as well. And my lab really focus on sort of image-guided interventions for anything. And so it's not really limited to neurosurgery per se. And so, for example, we use a neural navigation, but really surgical navigation can be applied to general surgery, to plastic surgery, to other things as well. We use optical techniques to look at endovascular surgery, but really the optical techniques can be used for ophthalmology and the ENT and other things as well. So as a key example, probably to look at the neural navigation is a interesting phenomenon that happened in our lab, and then probably to let you know what does it mean for a clinical translation. And so here is the initial napkin of how we sketch out, where can we place surgical navigation or surgical GPS devices, and perhaps the best place to put them is in the operating room light. So this is the initial engineering sketch of how one may do this. And then here's the technology that we'll use to do that. And the interesting thing is that the technology used, it comes as a hard moment that you may come to in any other scenario as well. So here we are just looking at the kids are playing with a sandbox, and then we have an optical detector figuring out the height of the sandbox and projecting different lights onto that. And that really shows you the anatomy, if you will, of the sandbox. But the same analogy and the same technique being used in this case as spinal surgery to figure out the up and down, the hills and valleys around the spinal bony structure, and then that can be used for surgical navigation purposes. Now, putting these things together is the task of engineer, but I want you to recognize a lot of the students in my research group, they are actually not engineers. They're supported by engineers, and then with that, the clinical translation can be held to actually work through animal lab and human cadaveric studies, and then eventually leading to FDA and Health Canada approval, and then finally getting to more complex cases, even down in half the global way. So this is a pediatric case. You can see the patient here in the halo and have a significant scoliosis, and then this is down in Australia now, and the other physicians now are using a clinically approved product now and applying this, and then essentially changing the lives of this pediatric patient. So this can happen in cranial navigation as well. So again, the different application field, but very, very similar technology. So therefore, the research that you're doing is not necessarily tied to actually the clinical field or clinical specialty that you'll be choosing. The key thing here to recognize is that with all of these research, the point is to make sure that we are advancing not only science, but also advancing clinical care. Maybe small baby steps in engineering terms. We like to make a small baby steps in making changes. But when you add them all together, we can have a revolution, so to speak. So all of these things are finding their way, seeping into different clinical application areas, and all of them. I want to emphasize that you can't really make real changes in the real world unless these are structured into commercialization and knowledge translation that eventually a company is being set up to do this. So with all of this together, the students in my group, that they win many awards. So for example, here are technology awards, actually 2 of them for the spine technology development. They actually win commercial awards like Frost and Sullivan awards for new product innovation. And then perhaps the most important one will be actually winning at the Congress of Neurological Surgeons for innovation. So these are actually trainee awards. Of course, they're group awards, group efforts from the research group, but the trainees do very well. They win external awards and the fellowship scholarships as well. With navigation, then it lends itself very well to surgical robotics. So here are some of sort of the robotics applications that's being developed in the lab, and then certainly the student here, the surgeon trainee here, are being supported by a large group of engineering research assistants. So you don't have to fear that if you don't have engineering background that you cannot get into this. And just very quickly to look at some of the optics. So here's the optical coherence tomography looking into blood vessels, and then our research group applied that not only in the eye but also in neurovascular interventions, and this can be applied to other vascular interventions in peripheral vasculature, in coronary vasculature, and then we are also the only group in the world can do Doppler imaging using optical techniques like this. And as I said, the students are supported by a large group of engineers, and the fundings, interestingly, is that while we receive a lot of tri-council funding, that there are probably about 3 to 5 times higher private funding that's being matched to perform these commercializations, such that all of these technology can go to the commercial world and then get FDA and the Health Canada approvals. And I'll probably leave the questions to the end when everyone have a chance to discuss. But the most important thing I want to point out would be that is to have fun doing the research, and along the way you will change the world of surgery, and with our lab, with the companies, and you can set up one as well. Thank you, Dr. Failing.
Thank you, Victor. So it's a great example of translational research and innovation. So so super. So to switch gears, to talk about basic science research, we have asked both Rebecca Gladdy and Marcello Seipel to share their remarks.
So thanks very much for this opportunity. We did this joint night last year, and I think it was pretty interesting, the feedback that we got from trainees. And so I'm a surgical oncologist that's at Mount Sinai, and I have an independent research lab that's really basic science, but also translational. And tonight I'm just going to take an overview, and Dr. Seipel will also be talking about basic science. So one of the things that I want to say is that although historically that was the only type of scientific endeavor that people undertook, it still really is a fundamental domain that is really critical to advance patient care. So tonight I just want to say that basic science, you've seen some beautiful examples, is really critical and something to consider. And I wanted to really talk about that, provide some very brief guidance on how to decide, make decisions about graduate units, supervisors, and research focuses. And these are based on last year's questions. And then for the SSTPs that are online, just make some comments about what life is like on the other side of research training as a surgeon scientist. So I still think of basic science as the question of why. Why do things happen to our patients? How can we make it better? And one of the big advantages that you have as a PGY 1 and 2 is you're seeing patients every day, and you know what the important clinical questions are in your respective disciplines. And that's really what helps guide us develop research programs and really build these programs over the years in our career. Being an SSTP means you have the opportunity to really develop critical thinking skills, become a creative problem solver, and also, as previously mentioned, start to hone your skills in writing and oral communication. And that's a skill box that as an academic surgeon is really critical to conveying your work and your success outside of the University of Toronto to the international community. Just like being a great surgeon, being a scientist means you're going to work in teams. And I think we just had some beautiful examples of the neurosurgical imaging collaborations. And these research opportunities allow you to expand your world outside of the OR and outside of the hospital. And I always like to tell trainees that, you know, being an SSTP is an opportunity to learn how to fail. We don't think much about that in surgery because we're so geared to perfection and not making mistakes. But some of the best lessons you have as a scientist is the hypothesis that didn't work, but you found something else. And you learn to develop a whole different style of thinking and coming back to what you thought was the right way, but turned out to be something quite different and even more exciting. So how to pick your supervisor and topic, practically speaking, we've already discussed the University of Toronto is world-class. There is someone out there that's going to be a good supervisor for you. And you just have to investigate what's your right intellectual and also your personal fit for the focus time that you would spend in SSTP. I was thinking about this the other day, and I think it's important to try to explore beyond the busy clinical supervisors that you may spend a lot of time with. Within our divisions, we have breakdowns of clinical teachers and you know, someone like myself who's a surgeon scientist. We may not see you the same amount, but we're out leading larger projects and start to talk to people about who are the people who are involved in sort of larger team science. And practically speaking, when you're on call, go to the Department of Surgery webpage. It's very well maintained. In addition to that, you can look up prospective programs and research supervisors if you go to the respective research institutes where people work. Most of us have a hospital affiliation, but we often have another research institute webpage. And those web pages can really help you, and people have their own lab web pages to really see and contact a lot of supervisors to start to get a sense of what interests you. So as you make the decision, this is obviously true beyond basic science, you want to look for a supervisor that has a good track record of having graduate students. You want to be in a well-funded environment. COVID has certainly provided a lot of curveballs for people running research programs. And, you know, to be in a lab that's at the top of its game and is productive, there needs to be good grant capture and a good trainee publication record. And so that last slide that you saw really tells you that Dr. Yang is a well-funded individual, funded from many different sources. And that's going to bring success to you and the team. So that's an important thing to be aware of. If there's only one thing in my 5-minute talk, it's go to the lab meetings. That now we're on Zoom just like this. I think our attendance is actually better since we don't have to travel the same way we used to. And go to the group meetings and make sure that how the lab is run, the questions they ask, the science, and how they think and how they interact really appeals to you. We always make everybody who's going to join the lab come to our lab meetings first. It's really a way for everybody to see what the fit is like. There was an overview provided about graduate units, and that's less of a factor, and it's really more directed by your supervisor itself. So just specifically with respect to graduate units, that was a nice overview of IMS. I got my PhD from IMS, many of us did. It was really designed in part to help clinician scientists so that you could focus on your lab work, but also not necessarily have to have a very heavy course load. Other graduate units in basic science include laboratory medicine and pathobiology, immunology, medical genetics, depending on what arena that you're looking at. Are graduate units you can apply to, but they tend to want people to stay longer in the lab, 5 years, 6 years. So it doesn't mean you can't take courses in those other domains. Again, going back to the Institute of Medical Science is often a choice that people make. Another practical question is which degree should I do? A lot of people start off in a master's program. That allows you to make sure that that fit of the supervisor and the research is good for you, with a subsequent transfer to PhD. And can't endorse enough the discussion about getting your own independent funding. All my grad students are independently funded at this time. It's really important for your career. There's a lot of funding opportunities. And so don't let that dissuade you. Getting into the application process sooner at the university level, at the research institute level, there's a lot of opportunity for well-qualified people like yourselves. So with respect to the second half of what's life like as a surgeon scientist with a basic science lab, Everybody has a different philosophy about this. My own personal one is that it's good to harmonize your clinical practice with your research focus. That's a really hard task for you as a PGY 1 and 2, but you're already starting to get a sense of things that interest you. You know, I did my PhD in leukemia and I'm not studying leukemia anymore, but I learned a lot of fundamental tenets of molecular biology that have never left me. And I learned a lot of skills in that. So, you know, I didn't necessarily live that as a piece of advice, but I think it's something that's practical. You always want to take advantage of what your resources are as a surgeon and expertise, and you can't downplay that. Steve Gallinger's not on the line, but he was a good mentor to me. And he always stands up at high impact science meetings and basically says, I'm a surgeon, this is what I do. And it really allows you to formulate and create a unique experience within these basic science teams. I do think it's important to publish early in the areas that you see yourself in long term. So again, trying to have a focus is helpful if you can do that. And align yourself as you start to wind up SSTP and go back into residency with a strategic plan in your division, if that's available. So when you think of next steps beyond SSTP, we've talked about fellowships, but coming out on the other side as a basic scientist, you can share a lab or go it alone. I went it alone and that turned out to be a good choice for me, but there's many different formulas. And really it's critical to have institutional support, and that is really financial support and protected time. And that's really critical to your initial success. Engaging in team science is really important. Everybody brings different levels of expertise, and to really move fields forward, you need to have a lot of team players. And certainly, as mentioned by Dr. Jeske, that the advantage we bring is access to patient specimens. We have one of the biggest biorepositories of sarcoma in the world, and that just really opens up a lot of international collaborations. And finally, you will still be able to do this as a 1 and a 2, is start to think about the problems that are seminal in your field. And there are going to be cases you see that turn you on, and you're going to remember that patient for the rest of your career. And that's, I think, practically speaking, how a lot of us found our research paths. So Dr. Kappas really gave a very detailed slide about this, but if you think overall of what we have at the University of Toronto, you know, we've got an incredible transplant program that Dr. Seipel is going to talk about. It brings many different disciplines together. The cancer programs many of us work in, we create preclinical models. Many people have reclassified human cancers based on their work in surgery and developed novel therapies. And certainly the work that Michael's been doing in spinal cord injury and regeneration has really been critical. And trauma and the management of polytrauma patients and resuscitation of fluids has been a clinical trial, an area that the University of Toronto has contributed to. So just to wrap up, basic science summary, I do span basic science translational to clinical, but I do want to say that I'm always glad this was the choice I made. I think it allows for discovery. It is creative and collaborative. Words to think about is that at times, it doesn't happen many times in your career, but the times it happens, there are groundbreaking and transformative changes. And I don't discourage trainees from doing basic science. I think it's hard work just like surgery. And so I think a lot of the faculty on the call tonight are engaged in this, and we're all happy to speak to you about this and give you guidance, and also give you guidance for other researchers that may not be in the Department of Surgery, like Dr. Kappas said, but still would be an excellent training environment for you beyond the people that you may readily know. So those are the main things I want to say, and I'm certainly happy to follow up with any particular questions.
Thank you, Rebecca, for your insightful comments. And Marcelo, perhaps we could hear your remarks as well.
Sure, I'll just also share a few slides here. Okay. Can you see that?
Yes, we can, Marcelo.
Okay, yeah. So I think Dr. Glady gave a very comprehensive presentation of how, how to be prepared and what to expect, in a lab. So I'd like to talk a little bit about innovation and then basic science / translational science, just to give you a couple of examples. So I think one of the very important things you heard here, you have to be prepared for failure and criticism. And if everybody thinks is a great idea, it's likely not. And always have the end result in mind, and certainly be open for the unexpected. Many students in my lab, they start with an idea of starting one project, and down the road, sometimes they end up, depending on how the experiments go and what they find, they end up switching to different experiments, which can be sometimes a lot more successful. So you have to be flexible also on that regard. In making an impact, you have to bring your research to a patient benefit, and this is a long journey, but a very rewarding one. And involvement and learning in all steps of this journey, and as Victor mentioned, sometimes to bring to the benefit of the patients, you have to go all the way to commercialization. And you hear about that, and you observe this, and you participate on that in our lab activities. So I just want to give you one example of I think this qualifies more as a translational research, although I don't really see a lot of separation between, basic science and translational research. At the end of the day, you want to do this to get to the end of the road, which will be to benefit patients. So, you should, as a surgeon, you are seeing patients every day, and you see where the problems are. So you start with a clinical problem, and in this case here of this research, we noted that a lot of people die of end-stage lung disease, like a 4th cause of death in the Western world. And why they die is because we can't get enough organs to transplant them. Of course, also there's not effective medications at some point when the organs are too damaged. And why we don't have enough organs, then we ask ourselves, the main reason is actually not because there are not enough donors, but it's actually because we don't use 85% of the lungs from the donors that exist. And why we don't use them? Because they have a lot of injuries. And what is the solution there is really to treat and repair these injuries. But if you try to treat this in vivo, when, in the donor hospital, for example, you don't have enough time. It's often an hostile environment for the organ in an ICU, and a brain death, donor inflammation, infection, and so on and so forth. And, if you want to try in vivo, also other organs are affected. And so we came up with the idea that treating these organs ex vivo would be the ideal. And that's what basically, what this system shows here is, it's an ex vivo, it's a human lung here being, maintained at physiological conditions, and eventually it can be used as a platform to improve injury. Now, so this is basically, this was actually the topic of my master thesis, was the development of, at IMS, was the development of this system here. And again, there's a lot of studies to get, why we use each of these components and how to use them and so on and so forth. If you look when we started in the lab about 2005-06, then, you go through the animal experiments, and then you go through a pilot clinical trial, ethics board approval, first human transplant, and doesn't stop there. If you really want to benefit patients, you have to go to completion of a trial, a larger trial, Health Canada application, and then eventually approval and funding for clinical use and reimbursement. So it's a relatively long road, but as I mentioned, a very rewarding one, because you do see the benefits of that to the patients. And now, you get to that point, but there is a lot more that opportunity creates. So now you have this platform that the organ can be maintained at physiological conditions instead of just keeping them cold on ice, cooler. And then you can treat them with drugs, with biological agents, inhaled gases, cell therapy, gene therapy, etc. And just to give you one example of that, you know, as a transplant surgeon, you know, in the year of 2016, 17, I start noting that a lot of the donor calls I would get, the donors would be from overdose death. And unfortunately, also most of these donors also tested positive for hepatitis C because they use IV drug use. And basically, and this, just to give an idea, moved from 1% to 15% in some places in North America, up to 30–40% of all donors, they were overdose drug users. And the main problem with that, as I mentioned, is that they often test positive for hepatitis C. And when you look at the survival of transplanting an hepatitis C organ to someone that doesn't have hepatitis C, you can see in the blue curves here a much more dismal outcome. So basically, we could never do this. This was just a few cases done from a registry, but people on the practical standpoint were just declining these organs. And it was feeling really bad for me getting those calls with perfect organs, and knowing that the patient was dying, you know, besides me here needing a transplant and not being able to use because of this virus. And so we started studying, you know, could we actually clear this virus from the organ prior to doing the transplant? And that's where we came with some ideas of using energy and light therapies to actually, you know, clear the virus, which is not, you know, the hepatitis C virus is not inside the lung cells. It's just in the residual blood that permeates the organ. And we were able to develop then again with bioengineering and so on, this system to apply ultraviolet C and photodynamic therapy that very rapidly inactivates the virus. Again, this is just a very quick example here. This device, you know, this was the initial prototype. Now it has a much more robust device, but the virus is washed out of the lung and passes through this UVC device, and it's basically exploded here, and it no longer can infect liver cells in the patient. And we've shown this in the laboratory. You can see here the inactivation of HCV by UVC in the ex vivo system. In less than an hour, this virus, although somewhat detected by PCR, no longer could infect liver cells. And we, you know, after these studies, we did preclinical studies and safety studies. We were able to move then to a clinical trial of prevention of viral transmission using this methodology developed in the lab to benefit patients. So again, this is just to show you all the steps going from the lab to the clinic to benefit patients. And here just to show you the differences in the viral loads in the patients, and many patients didn't acquire hepatitis C, and the ones that did were treated with these new medications, the direct antiviral agents. So I'll finish here. I'll be happy to answer any questions.
Great, thank you, Marcelo. I think we'll hold questions. We'll sort of handle this kind of through the chat, and then we'll have some questions after the formal presentations. So the training in research in the Department of Surgery is recognized by the Clinician Investigator program of the Royal College, and this is there's an important representation, the CIP program here at the University of Toronto. This is directed by Nicola Jones, and so Professor Jones has kindly offered her time this evening to share a few thoughts. So Nicola, welcome, and thank you for participating.
Thank you very much. It's my pleasure. And I hope for all the trainees, you're getting inspired by all these talks. I mean, I certainly am. So I'm just going to share a few slides. If that's, can everybody see my slides okay?
Perfect.
Okay, great. So I'm the director for physician scientist training at the University of Toronto, and that includes the SIP program. And so if you don't know about SIP, SIP is a Royal College accredited program. So similar to your fellowship training. And the idea is that it's going to provide you with the skills that you need to become a clinician investigator or a clinician scientist. And it's the largest program in Canada. So we have about 140 trainees that are in the program, and they're either in graduate programs, or else you can also do a postdoctoral fellowship within the program. And the program is really an added value to your graduate studies or your postdoctoral fellowships. So when I think about becoming a clinician scientist or a surgical scientist, these are really the competencies that I think that you need to have. So discipline-specific foundational knowledge, patient care and clinical skills, research skills. But then there's these skills down here as well. So rigor, responsible conduct, personal and professional skills, communication skills, grantsmanship, leadership, managing a team, mentoring, and teaching. And that is really what the clinician investigator program provides to you. So an added value to give you those professional skills to become an effective and an excellent clinician investigator or clinician scientist. So how do we do that? So obviously you do coursework, which is part of your program, part of the surgical scientist training program. And there's coursework within the graduate program, but we also offer additional curriculum. So during your time in the SIP program, you will participate in 5 seminars or workshops, and you'll also organize one yourself. And really what I ask the SIP trainees to think about is, what is a gap as you're going through your training? What is a gap in your professional development? So maybe it is, how do I deal with conflict in authorship? How do I get a job? How do I do a job interview? Can be anything that you can imagine, but needs to be an interactive workshop. So you'll participate in 5 of those and do one yourself. We also have a unique online curriculum called SIP Core Ed, and that's really focused again on expanding your professional development. And I ask people to do these intentionally. So there's 8 modules. You can see the different topics. So for example, if you're starting to write up a paper, then do the manuscript writing online module. And then you can actually take those skills that you've developed from doing the module and use them, actually incorporate them into your practice. We also have a symposium, an annual symposium, and every other year it is a national symposium. So all of the clinician investigator programs across the country, as well as the MD, PhD programs, participate in this meeting. And so I'll just give you some examples. This is just an example of one of the online modules on grant writing. They're interactive. They take about 30 minutes to an hour to do, and they're meant, again, to provide you with additional skills that you would not get otherwise. This is the example of the scientific meeting for this year, and this year it is the National Symposium. And this is just one day, but you can see we've got a fantastic keynote speaker. So Dr. Michael Strong, the president of CIHR, will come and talk to us. We've got a variety of workshops. And again, if you think about those competencies, these workshops are aimed at helping you with those. So for example, developing strategies to maintain wellness, understanding the hidden curriculum, hiring a clinician scientist trainee, COVID-19, a case study for pivoting your research. So here we utilized scientists across the university and actually across the country who had taken their research and pivoted to include COVID-19. So they weren't already working on COVID-19, and maybe they leveraged an existing network, an existing diagnostic, or develop some completely new lines of basic research to study COVID-19. So why would you pivot? How do you develop collaborations? How do you get funding? When is the right time to do so, etc. So again, you can see that this additional curriculum is building on your professional skills. So I'm not going to belabor any of these points. I'm happy to answer questions afterwards, but certainly what I thought might be important is the application deadlines. So we have Ministry of Health funding to support SIP trainees. There's 14 SIP funded MOH positions each year, and January is the timeline for that, for applying, and that's if you're enrolling in July. And November is enrollment for January. If you're already in the program and you don't have MOH funding from SIP, you can apply as well. So with that, I'm just gonna end, and I hope that you consider that the added value of the SIP program when we really welcome the surgical scientist trainees to SIP. So thank you, and I'm happy to answer questions when we have the question period.
Thank you very much, Nicola. That was excellent. We'll be able to get a copy of your slides, I trust, and we'll kind of send those around as part of the package as well. There's quite a bit of excellent information there. Perfect. So another area of research, which has been alluded to by a few of the speakers, is biomedical engineering, and we're privileged to have Dr. Warren Chan, who's the director of the Institute of Biomedical Engineering, to just to give a quick overview of the research opportunities in engineering.
Thank you, Michael. Yeah, so my name is Warren Chan. I'm the director of the Institute of Biomedical Engineering at UT. So our former name, which you may recognize some of our brand, was the Institute of Biomaterials and Biomedical Engineering, so IBBME. And we made this change in the name this last year. So the Institute is actually a very unique structure within the university. The reason for that is because it's actually financially supported by 3 different faculty: applied science and engineering, medicine, and dentistry. So all of these different faculties actually contribute to the activities within the Institute. The focus of the Institute is essentially to use engineering principles to solve some of the most pressing healthcare challenges. But what's unique about what we do is that the fundamental basis of the Institute is engineering. And we actually work with a lot of clinicians, dentists, and other collaborators to essentially solve their particular issues. So the Institute right now has approximately 400 graduate students. And in the last 2 years, there's been a huge increase of interest in biomedical engineering. We were at about 280 students a couple of years ago, and now we're close to 400. Our number of applicants into our program went from 300 to about 620 at this particular point, with about 20% acceptance rate. The faculty in the Institute has approximately $12 million in research funding overall. There's approximately $6 million in student support. We partner with 10 different hospitals in the Greater Toronto area, and we have 3 main research themes within the Institute. Just to have a breakdown of the Institute, we have 39 core faculty. So these are the faculty that's involved in running the Institute on a day-by-day basis. 26 of those faculties are actually paid by the university. The other 13 are people at the hospital that are heavily involved with the Institute. There's 79 cross appointments within the Institute. So a lot of these cross appointments are actually at the different hospitals. So a lot of our students can be anywhere from Toronto Western to the St. George campus in the engineering building. So they span across the entire range. But the Institute in the last couple of years have been actually focused on increasing the number of core faculty within the Institute. So we've been on a little bit of a hiring spree the last couple of years. In the last year and a half, we've hired 3 new faculty in the areas of molecular engineering and immunoengineering. We just made an offer out for a researcher who works in the cardiovascular engineering space. So Daniel works on wearable electronics to manipulate heart function. And we're looking at hiring another 3 to 4 more faculty in the next year to 2 in the areas of molecular engineering, regenerative medicine, and device engineering. So As you can see from the theme here, we're actually trying to present or provide new expertise in the engineering space into the GTA community. There are essentially 5 major research program or graduate programs in the Institute. 2 of them are research-based, Master of Applied Science and the Doctor of Philosophy or PhD. And there's 3 professional programs at this particular point. Master of Health Science, which we call the Clinical Engineering Program. The Masters of Engineering, which is a 1-year course-based program. And again, the focus there is biomedical devices and commercial translation. And we're starting to pilot, or we have piloted a combined MD-MEng program. So the purpose of this program is actually to teach MDs some of the basic principles or some of the tools and techniques that they will eventually use for diagnosing patients, treating patients. So it's less heavy on the math, but more heavy on the concepts of some of these technologies. The Institute has students from a variety of different backgrounds. So we don't just accept engineering students who come into our graduate program. So our students' education background includes engineering, chemistry, biology, psychology, dentistry, and I think we actually have 1 student who's in the soft sciences, sociology. So they essentially learn engineering principles to apply to sociological problems. So there's 3 major themes in the Institute. Molecular engineering, which encompasses concepts such as nanotechnology, molecular imaging systems biology. Cell and tissue engineering, which involve biomaterials, tissue engineering, and regenerative medicine. And third is clinical engineering, neuroengineering, sensory engineering, and rehab engineering. Just to provide some perspective in some of the work that's happening within the Institute. For example, my lab is in the molecular engineering space, and we're developing handheld smartphone devices for diagnosing COVID-19. We were developing this for Zika, chikungunya, and dengue, and because of the pandemic, we sort of evolved our device now for COVID detection. Professor Chang is working on developing artificial intelligence and MRI contrast agents for cancer detection and for human tissue repair. We've already heard earlier about Paul Santerre, so he's a core faculty, and he's developing soft tissue fillers for the reconstruction of breast cancer defects, so that's one of his many areas of research. Professor Radozik is developing engineering lab-grown heart and liver tissues for drug testing. So she actually takes patient cells and then recapitulate and regrow them into artificial tissues that you can use this for screening without having to do this in humans or animals. On the more clinical side, a lot of our researchers are working directly with patients. For example, Jan Andrzejczyk is building devices and electronic support for patients with physical disabilities. Elaine Bettis is developing virtual reality and video game therapy for children in rehab. So she's essentially a programmer, so she's developing all the coding schemes for these programs. But one of the things that's very unique about the Institute is that a number of us actually started our own companies. So I have a company that develops diagnostics. Paul Santerre has a company that develops biomaterials. And Jan Andrzejczyk here has a company that commercializes the electronic support. So all of our companies, we start with the concept, we fundraise, and then we actually translate this into the real world. So I just want to also mention that we have 2 over $100 million major initiatives within the Institute right now. One of them is a generous donation from Ted Rogers, the Translational Biology and Engineering Program. It's led by Dr. Craig Simmons, and the objective is to engineer new cardiovascular diagnostics and therapies. Another one is led by Michael Sefton's Medicine by Design. It's a new strategies to engineer regenerative medicine. So they're both core faculties within the Institute, and they work with the hospitals to essentially manage these big programs. But as I mentioned, what's unique about the Institute is that we're actually bringing technology to the community. And then the community essentially works with a lot of the clinicians for some of the clinical problems and translation. So some of the areas that we're going to continue to grow in the next bunch of years are areas of immunoengineering, synthetic genomics, wearable devices, molecular engineering, nanotechnology, machine learning, or artificial intelligence. So we tend to be more the developer rather than the user at the end. And so one of the comments I actually want to suggest is that if there are certain scientists who want to come to the program, one of their big concerns is that the topic of research doesn't actually match their clinical specialty. So we say that's okay. The reason for that is because if you come into the Institute, you'll learn a new technique, a new tool that can be adaptable to a number of different areas. A good example is a former surgeon scientist that joined my lab, Kim Choi. So she was an orthopedic surgeon, And so she joined my lab and worked on designing nanoparticles for targeting cancer. Nothing to do with orthopedic surgery, but she learned all these concepts, and now she's an independent investigator at Mount Sinai. And it's funny that she's now, she said she's never going to do nano again after she left my lab. But now actually nano is starting to be, she's thinking as being a key platform for delivering different drugs for different types of osteosarcomas in kids. So again, like learn new technology because you have good clinical practice and you know what you're doing from that perspective. It actually allows you to integrate and implement a new technology in a field. And especially if your clinical field doesn't actually have any of these technology, it provides a huge advantage. So you can actually go into the biomedical engineering website. So we have 2 websites to give you a sense of what the student life is like, what the faculty life and the interaction. So we actually created a new website called discover.bme.utoronto.ca. And Sean suggests you look at the Biomedical Engineering magazine. It gives you a sense of the entire institute in one magazine. And more the administrative site is bme.utoronto.ca. Because I actually have to run, feel free to ask me any questions. I put my email up. Just send me an email and I'd be happy to answer any questions about anything about the Institute. So thank you.
Thank you very much, Warren. Most appreciated. So we're going to shift gears and we're going to talk about clinical epidemiology research, and we'll go a little bit out of order and ask Dr. Abhi Sriharan to talk to us about the IHPME program, and then we'll go back to Girish Kulkarni and Natalie Coburn.
Perfect. Hi, everyone. Thank you for this opportunity. I'm just going to give you a high-level overview about the Institute of Health Policy Management and Evaluation, and particularly one of our new programs. And then I know Girish and Natalie are going to talk about the EPI program in detail. So IHPME, we work on a number of issues that has to do with health systems and health services delivery. So if you are interested in research around leadership, service delivery, health workforce training, information systems, medical technologies, health economics, health policy, we are the home. We are based at the Dalla Lana School of Public Health, and we have a couple of different types of programs. So one is purely research degrees, 3 types of research degrees: health services research, which covers areas around health economics, informatics research, health policy research, organization and management, outcomes and evaluation, artificial intelligence is a brand new emphasis, and then technology assessment. We also have a clinical epidemiology and healthcare research program. And then the final one is health professions education research. So if you're interested in research in education, we have a program and PhD program. We also have, similar to the IBBME, we also have professional degree programs. We have a master's in health services administration. It's a management degree, and we call it MBA for health services leaders. And we also have a master's in health informatics. There's 2 tracks. One is a regular track, and there's also an executive track of MHI program. The new type of programs, and we have a 3rd type, operational research, which is basically kind of combining the management leadership with research to give more practitioner-led initiatives. So the new program that I'm just going to touch on is called Masters in Health Systems Leadership and Innovation. We also have a master's degree in quality improvement and patient safety. So Systems Leadership and Innovation program is exclusive to physicians, emerging physician leaders who are interested in systems leadership and innovation. So how do you bring micro level innovations to systems issues and policy transformation? And SLI focuses on this intersection between clinical microsystems. So you have basic science, so clinical research, but if you want to bring that to scaling, uptake, or spread of those innovations into health systems, how do we do that? And that's the focus of our program. And the 4 competency areas that we touch on are systems leadership. So goes into specific leadership competencies, policy, health policy, how do you do data-driven policies, health advocacy, health economics, comparative health systems, strategy around system, how do you bring in systems thinking? So interesting innovations, but not all innovations get into policy. So how do we transform that strategic mindset, business, finance and accounting, sorry. And then we also go into innovation at the macro scale. The program is about 20 months in duration if someone wants to do it as an accelerated pathway. As part of the program, the students have to do a capstone. So we don't call it thesis, we call it capstone project, but it's similar to a thesis where they have to identify a project, they have to create a capstone advisory committee with a site-based supervisor and an IHPME-based supervisor, do a research proposal similar to a PhD project. The proposal has to be approved by the capstone advisory committee, and then the learner goes into innovation design and implementation, and then outcomes evaluation process. At the end of the public things, the students have to publish a manuscript based on the capstone project to be able to graduate from the program. So it could take anywhere from 20 to 24 months to complete this degree program. So I'm going to stop here, and I'm just going to give you the website address. This is our IHPME website address, and if you go there, you would find all the information about the program. You could also follow us on Twitter. My Twitter information and my UToronto address is here as well. Please feel free to reach out with any specific questions. Okay, I'll stop
Great.
here.
Thank you so much, Abby. And then Girish and Natalie, if we could perhaps hear your presentations next. Thank you so much.
Okay, I think Girish is going to go first because he had to leave, but maybe he's already left. Girish, are you still there? There he is.
Yeah, I'm still here. Sorry, I may have to leave soon. So we will keep this brief because we want to have time for questions at the very end. I don't have slides to present, so I want to keep this very informal. Clinical epidemiology is a very vast specialty. So it's basically a merger of epidemiology and clinical medicine. And so that can encompass a lot of different research projects. I am a urologic oncologist at Princess Margaret Hospital, and I did my PhD in ClinEpi, and I did it through the IHPME program. And one of the reasons I sought this out, particularly ClinEpi, was because it was a field of research that was very close to the bedside. So it was like a clinical bench to a clinical bedside, as opposed to a translational or basic science bench. And that was just simply my interest, and that's why I embarked on that course. Like Dr. Glady mentioned, I started with a master's, and I think it's a reasonable way to start. And if you enjoy what you're doing, you could then branch off and extend to do a PhD, assuming your supervisor is on board and you have an appropriate project. In terms of supervisors, I think that's very important to select, as Dr. Glady had mentioned as well. It's really important, I think, as surgeons to find someone who will make time for you. So the busy clinical surgeon may not be the right person, or the busy researcher who is flying around the world giving talks pre-COVID, I guess now flying around Zoom and giving talks. That you need someone who is going to give you time, read your papers in a reasonable amount of time, set up meetings with you on a regular basis so that they can guide you along the way. And I think as you go through your residency, you will figure out who those people are. Also, in terms of a supervisor, it's not a bad idea to pick out collaborators as well. So for example, if you're an orthopedic surgeon and you have an interest in decision modeling, or you want to do decision models in orthopedics, there may not be an orthopedic surgeon that has that background. I actually don't know, that there could be. But if there isn't, you would pick out someone who does have that expertise and have them co-supervise you as well. So we have that model quite commonly in urology, where we will have a non-urologist on the thesis committee as well. Now, in terms of the types of projects that can be done, a lot of the projects that are done by clinical epidemiology students nowadays are database type projects. So through ICES, we have a great repository of data up at Sunnybrook and G-Wing. Examples of people who have done those projects include Chris Wallace, Amanda Hurd in urology, and like I did not mine there, so did Anand Govindarajan as examples. There's plenty of people who have, but you don't have to limit yourself to ICES. You could use SEER data for your project, or even NISQIP data, which is readily available. Other types of projects in ClinEpi that are available are qualitative methods type of projects. For example, quality of life or patient-reported outcomes projects would qualify. Modeling studies, so if you have an interest in Markov modeling or Monte Carlo simulations using Python, you're mathematically oriented, you can do that through ClinEpi or even through HSR. And those types of projects are quite clinically applicable. For example, determining the cost effectiveness of a new health technology. The final thing I will say before I let Natalie say a few words is regarding randomized control trials. That's probably the holy grail of the type of project you can do during clinical epidemiology. They're tough to do and they take a long time to complete. So we don't see many master's students pulling that off. Most likely you would have to have something set up before you got into the SSTP program. And as PGY 1s and 2s, that may be something that is of interest to you, but start now, unless you do a PhD. Then you have 4 years. And even then, 4 years may not be enough, depending on the disease site, the rarity, and the complexity of a trial. But with the right supervisor and the right guidance, you can pull off many of these different projects. And it's actually quite common for the surgeons to have the highest completion rate in ClinEpi. I sit on the ClinEpi admissions panel, and the surgeon scientist trainees actually do quite well getting into the program because they're known to complete the program in 2 years. You only have 2 years of funding, or 4 years if you're going to do a PhD. They often have their projects aligned, their funding aligned, so all their ducks are aligned, so they're sought after candidates. I'll now turn it over to Natalie.
Yeah, that's a great overview. I think what the residents can see here is that there's really something for everyone, whether you're interested in basic science or if you're interested in clinical epidemiology or anything in between. I know this is an SSTP discussion, but I think it should also be said that some of these projects can be done without going through a formal SSTP process. If you're interested in that, everyone doesn't have to apply to a master's. There are other mechanisms to do projects on the side. I think what Dr. Gladdy talked about is really important. If you're interested in a project or an idea, sit down and talk with the surgeons. Call whoever you're interested in talking to and say, hey, I'm interested in this project. What do you think? And they'll tell you pretty straight up if they think it's something that can be done or they think it's not. Talk to the other SSTP students. And I think one of the comments was about involving people outside of surgery on your thesis committee. I think that's a really important thing to do. I think quite often we end up with a surgeon, training surgeon scientist, and having a PhD co-supervising or even supervising the surgeons. I think you'll find those residents learn a lot. As far as IHPME goes, you do have to keep in mind the deadline is sneaking up really soon. It's November 15th. It is a highly competitive process. So I'm not sure exactly how many people apply into it, but I do know that there are many people who don't get into the program. And as Garesh said, the surgeons usually do very well. And the reason we do very well within this process is because the residents are almost always well prepared with a good project some of them with funding, but there's only 30 students in the ClinEpi class. So, you know, as you can imagine, if there's 5 or 6 surgeons who are applying, they probably don't want 25% of their class to be made up of surgeons. So I would look at the other options within IHPME. There's many more offerings now than there were before, and they're very good programs. The HSR program is excellent. The QI project program is very new, but I've heard very good things about that as well. And Dr. Shaharan can talk to you about that. So since we're running really pretty late, I'm not going to say much more and turn it over to the next speaker.
Thank you very much, Natalie and Girish and Abby. So thanks, good summary of the clinical epidemiology research opportunities. So another area of research opportunity relates to surgical education, which is, I think, a real strength at the University of Toronto. And to speak about this opportunity, we've asked Dr. Carol Ann Moulton. Carol Ann?
Hi, thank you. Can you see me? Can you hear me? Hello?
Both are A-OK.
Okay, good. So I'm going to give you a really quick overview of education. I know we are running out of time. I think one of the misunderstandings in education is the topics that you can actually cover. I know that a lot of people think of surgical education as technical skills, simulation, and we certainly have a lot of expertise at U of T around both of those. We have interesting research projects that have come out of Theodore Grancheroff's Black Box. And so he runs a very big research program around that. We have people involved in curricular development, understanding how we set curricula, whether it's actually in the lab or in just the surgical residency program. We have topics such as team collaboration and communication, which I think is very important and a very big part of becoming a successful surgeon or a surgical expert. Myself, I study more of the social sciences. So I look at my own lab and interest started with the idea of what makes expert judgment. And so what is it that experts do that make them expert in terms of decision-making and cognitive processes? And, you know, I never really thought of that as an education field before, but my introduction to a lot of these different aspects of education came when I joined the Wilson Center for Research and Education, which is actually centered in Toronto General Hospital, but it's a combined effort between UHN and U of T. And funded by both. And there you'll find a lot of eclectic different scientists that are really interested in research in education. And so you can look at people or talk to people or have a supervisor who's very interested in, say, Foucault's work on power. You can look at the power dynamics in surgery. You can look at behavior. We have anthropologists, we have psychologists. We have a lot of people interested in culture. And so understanding the surgical culture, understanding how the culture affects our decisions, all of those things you can cover within the bigger field of education. We have people interested in gender, people interested in all sorts of different things, equity, etc. There's a wide range of things you can do as a surgeon scientist. The PhD is actually now through the IHPME, but through the Wilson Center. So we are actually now considered a degree granting agency and offer their own PhD in education. We also have people enrolled in IMS and OISE and different faculties across sections. There's a difference between, I think someone should maybe mute, I think someone come online, but there's a difference between the degree at the Wilson Center and being a fellow. You can actually be enrolled in many different programs across the world in education. You can get a master's, you can get a PhD in education, and still be enrolled in the fellowship program at the Wilson Center. So I think there are kind of two distinctions that are very important. There's lots of different supervisors, as I said. They come from a wide range of areas. You can have a surgeon supervisor. We have many different surgeon educators across U of T, and you can have also a Wilson Center scientist, which are not surgically trained or surgically minded, but they are interested in something from a theoretical perspective that can then shed light on something surgical. You know, the career that you get with education is, you know, varied. You can be involved with administration. You can run programs, be a program director, and you can have your own research program, particularly if you do a PhD. So I'll stop there, and I'm happy to take any questions or happy to have anybody reach out to me, and I can, you know, set you up with the right person.
Okay, wonderful, wonderful. Very broad area to cover, but certainly education is a major strength at the university, and the Wilson Center is a special resource. Thank you. So we've perhaps gone a little bit out of order, but we're going to go back to bioengineering research, and Dr. Monica Farkas is going to share her remarks on this. And that'll be the last kind of semi-formal presentation of the evening.
Thank you very much. Sorry, my video doesn't seem to work, but hopefully my screen will be can be shared. There you go. Can everyone see that?
Yes, we can, Monica. Looks great.
Okay, perfect. Thank you. So I have a few brief slides. I'm going to try to keep it very brief. I know it's been a long evening. Essentially, what I wanted to tell you about is the fact that there are numerous opportunities for getting involved in bioengineering and innovation within the Department of Surgery at U of T. And in fact, the Department of Surgery has recently formally created an academic job description, which is called the Surgeon Entrepreneur. And this recognizes the efforts that surgeons at U of T have been dedicating to innovation, whether this be device development or essentially any kind of innovation. I mean, you've heard many of stories of innovation already tonight, be that new surgical techniques, not just devices in themselves. So that really puts things into perspective, that innovation is really at the forefront of research within a U of T, and is supported by U of T. This is the first time I've been asked to speak to the SSTP students, and I am a urology surgeon at St. Michael's Hospital. I do robotics and minimally invasive surgery, as well as kidney transplantation, but I was actually trained as an engineer before studying medicine, and I run a lab myself that's a hybrid of clinicians, of engineers, and then some people just like me who have both backgrounds of engineering and clinical background. And we focus on the development of medical devices, and I am not unique to this space. There are ample opportunities to work with other surgeons who have spearheaded innovation at U of T, and I've just listed some here. This is by no means a comprehensive list, but you'll see, for example, there are people like Karen Cross, who's a plastic surgeon at St. Michael's Hospital. She developed the foot screening device for diabetic patients, and many of these people, as you'll see, have started their own companies. Her company is called Mimosa Diagnostics, and she's the founder and CEO of this. Dr. Resende Neto is a general surgeon also at St. Michael's Hospital. He's a trauma surgeon, and he has actually invented multiple devices over the years. Something called the liver airbag, which protects the livers in trauma patients. He's developed an abdominal binder that helps with wound healing, tracheostomy device, etc. And together with Dr. Ori Rothstein, they started a company as well called Inventor MD. A few other people, just Dr. Vito Forte is an ENT surgeon at the Hospital for Sick Kids. He's currently retired from clinical practice, but in fact, before he retired from clinical practice, he started what's called AutoSim. So many of you know this very well. It's very commonplace. You've been trained on AutoSim and OptoSim. Well, before Vito came along a few years ago with the idea that, you know, medical students and nursing students are not well taught in these techniques. I remember going through this, and you know, you'd look on your OSCEs inside the ear, say, do you see a, yes, I see this, I see a cone of light, but nobody really saw anything. So he really kind of took this to the forefront and made these simulators, which many of you use now daily, and they're used across the world. Dr. Theo Grantcharov, who's already mentioned, is a leader at U of T within surgical simulation and surgical safety with the black box OR. Dr. Shaf Kashavji, and you heard from Dr. Saipel. This is exactly the same technology Dr. Saipel was talking about, ex vivo, which he had worked on, developed this perfusion system to repair injured human donor lungs. So it's a kind of a nice tie that you see here between things that have been discussed with respect to a connection between basic science, between new technologies and innovation, and translational research. It all kind of ties together, but right now there is, as I said, an official platform where you can be supported as a surgeon entrepreneur within U of T come your academic career days. So just to briefly leave you, sometimes innovation can be a lot of fun as well. So here, this is Dr. Derazende Neto, who I mentioned, also Dr. Cardura, who's a vascular surgeon, and myself. We actually competed in essentially Dragon's Den. It's called Angel's Den for innovation. So we're doing a Dragon's Den for research and innovation for our devices. And this was done at Kerner Hall. This is last year. Our judges were the Dragon's Den judges. We had Michelle Romanov and Vincenzo Guzzo and Joan Minman judging us, and the prizes were research money. So it could be a lot of fun. So I'll leave it at that, and I'll be happy to answer any questions.
Thank you so much. Really super. Okay, so we're running a little bit over time, and perhaps we've been a little ambitious. This is our first attempt at trying to convert what in essence had been kind of a live event into a virtual event, but there's been a lot of information conveyed. So we'll provide the materials in kind of an electronic format. Just before we hear from our recent SSTP graduates and our current SSTP research committee reps, I wanted to just briefly introduce Nancy Kondo from our Department of Surgery administrative team. Nancy, thanks for participating this evening. Can maybe introduce yourself and kind of what your role is, and how you can be of assistance to the surgical residents as they embark on their research training.
Thank you, Dr. Failing. So I'm Nancy Kondo, and I'm the business manager for the Department of Surgery. And one of my roles is working with Val very closely in administering the surgeon scientist training program. So if you are currently in the program, you are familiar with me because I constantly bother you with regards to applying for awards, etc. So I'm here if you have any questions. Val and I are both here. Actually, we were trying to put together a forum where if you do have any questions, you can ask us. And we had planned to do something in, I believe, June, right, Val? But then COVID hit. So Val and I are exploring having sort of like an open forum and a meeting through Zoom, where if you do have any questions, we can answer them for you. By all means, please do not hesitate to contact me. I know that it is complicated, especially with the funding model, but I'm here to help if you have any questions. Thank you.
Thank you, Nancy. And the administrative team is wonderful in the Department of Surgery, and they're there to really address any of your administrative questions and to to allow you to focus on the research. I realize that we're approaching kind of the official end of the evening, but I wanted to allow our recent SSTP graduates to say a few brief comments, and then have introduce you to our current SSTP Research Committee reps. And then I was speaking with Lorene and Doug, and we'll speak in a moment, in advance of this evening. And normally one of the highlights of the evening when we would do this live is that we normally would have round tables. And then after the formal presentations, we would have some informal discussions. And I was speaking with Doug and Lorene and Val earlier today, and we thought what we might do to try to simulate this is to create through Zoom an opportunity to have these informal discussions. So there will be no formal presentations. We'll have the materials available for people to review. And through Zoom, one can set up rooms and kind of chat line opportunities. So we thought that we would actually follow up this evening kind of with that kind of an opportunity. So perhaps if I could call on our recent SSTP graduates. So we have Uni Zhang, Mitchell Goldenberg, and Hélène Retrouvi. You'd maybe just say a few brief comments on your experience, and if you would be able to make yourselves available for a subsequent kind of open discussion, that would be amazing.
I'm happy to jump in first. First of all, thank you to all the faculty who gave such great talks. I think it's kind of a funny concept of asking the recent graduates to speak when pretty much all the faculty have also gone through the program. So I think all of us have our own unique points of view. What I wanted to say, because I think everything has been said to some extent, but just to add that, don't be afraid to look outside of your own specialty. So I did my research with Theodore Grancharov. So I met him doing an off-service rotation as a PGY1, and we immediately connected on a lot of different fronts, including the sort of academic side of things. And I was very well supported within my own division to work with him in sort of consultation with faculty within the division of urology. In addition to that, what I would say is try to identify a research question early. It's very difficult when you're sort of embarking on this big step to try and immediately hone down on one area to focus on. But I found it quite helpful because it allowed me to set up my 3 years to set up multiple studies to address the same question or the same field. And that allowed me to, or sort of takes me to my third point, which is try and find your niche, and also try and find your group of people within your field. Research is obviously such a broad topic and such a broad area. The education world where I sort of lived is in particular quite broad, as we heard. And so I really wanted to find the academics at different sites and within Toronto who had a common interest as I did, and I found that quite helpful in terms of collaborating and also going to different conferences and being able to sort of find your group of people rather than sort of being lost amongst many academic minds. So I'm happy to answer any questions. I think everything's been said quite well, and I'm happy to stay after if there were doing any sort of breakout sessions.
Thank you. Thank you. Very gracious. Okay, I don't know who wants to go next, Uni or Hélène?
Sure, I can go next. This is Uni. Thank you for the opportunity and for inviting me to represent the general surgical scientist training program graduates. The only small tidbits that I'd like to bestow upon any trainees considering SSTP are one, sort of to follow up on Mitch's point about picking your research question early. Although it's important to figure out whether you want to do a master's and or a PhD, and to start with the master's. If you do want to pursue a PhD, which I didn't, but I think it's better if you consider that early. I know of trainees that the project that they chose for their master's didn't necessarily translate well into a PhD degree. So, and also funding is a little bit easier if you are aware of your goals in that regard early. And if pursuing a course-based thesis program, then use the coursework to use your coursework to work towards papers so that your productivity is increased, and collaborate with your peers within the classes to also increase your productivity. This is also a great opportunity with presentations and podiums and posters to travel. And also opportunities around that. I had the opportunity to go to a gastric cancer meeting and also to attend a master class within that meeting to watch surgeons in Korea operate. So that had relevance of not only research-wise, but clinically. And lastly, to not only find mentors for research, but also to find mentors to help you through the various transitions. One, to transition into the SSTP program, the journey throughout SSTP, and also the transition back to clinical. I think mentorship is important for those 3 stages of this. Thanks. And I'm happy to stay afterwards as well.
Oh, thank you, very gracious. Hélène?
I think that was really excellent. Thank you for inviting me tonight. I just wanted to add to the discussion in terms of being flexible as well, in terms of courses and where you will select to go. So I decided to do clinical epidemiology, but my research ended up being qualitative in nature. So it was a bit different because clinical epidemiology is usually quantitative research. But within that, I was able to build a research team and find coursework a little bit outside of ClinEpi to be able to achieve both my thesis goals as well as my personal goals of having a very strong quantitative background. So I think when you're thinking about this, you want to think about your mentorship and your research supervisor, your clinical supervisors, and the field that you want to go into, but also you can also be flexible and pick a field or an area and know that wherever you end up, you can make it work and end up being very successful. And I think the last tidbit of advice is for funding and awards. I think some students are sometimes worried that they don't fit exactly the criteria, but I think SSTP is a good time to learn to be a clinician scientist and to really try out different things. So I would encourage you to just try to apply broadly to awards and grants in different fields. You may not be the most competitive when you start, but you'll get feedback and you'll get better. And then you'll end up securing some good funding, which will build for your career as a surgeon scientist. So I think it's a good time to learn and to maybe face some failures, but then that will make you better in your career. And I'm happy to stay to answer any questions, or you can also email me.
Oh, thank you so much. Okay, that's wonderful. So I did a shout out right at the beginning to Lorene and Douglas, our 2 resident representatives on the research committee, and they serve extremely important roles. And Lorene and Doug, comments from yourselves.
Sure, I can go first. So thank you to all of the faculty members for everyone's talks tonight and to give us the opportunity to speak. I don't want to belabor and repeat too much of what's already been said, but really to reiterate, for those of you contemplating it, I truly believe that this is one of the best decisions that you can make for your academic career. As you've heard, the support that we get and the opportunities are truly unique, both within your division, but also looking across the entire university to connect with top minds, the funding support. It's a wonderful resource. You will get to build your academic portfolio, engage in grant writing, really set yourself up for independent practice and explore kind of beyond what you would be able to in clinical residency alone. As a last point, I just cannot overstate how having a supervisor and a thesis committee really does feel to me that I've gained 4 mentors, friends, people that I'm continuing to build a relationship with and learn from. The opportunity is really whatever you make of it and extends far beyond the degree and the letters themselves. Laureen?
Yeah, so I mean, me and Doug are here if you guys have any questions, you know, in the process of entering the SSTP and also throughout the process, we're here to represent you. So you can always reach out to us. Our emails are online. And as Dr. Failing said, we're hoping to have a couple kind of more informal interactive sessions just to help with that transition to the research side. You guys all saw the fantastic kind of spectrum of research options. And I think really this is probably one of the only times that you will, or us as trainees will have in our career to have fully dedicated protective time to explore our research interests and really kind of stretch that limits of creativity. And I think in one of the most important things that the other trainees have mentioned is choosing, you know, a mentor and a supervisor and a lab that you feel kind of meets your future goals, not just from a research setting, but can kind of pave your way forward. And, you know, you can have your question going in, but if you're in a setting that can obviously add to your ideas and make them, you know, much more kind of better along the way, that will kind of really help you throughout the way.
Cool. So we were supposed to end at 7. It's about 10 after 7. So normally during an evening like this, we would have been sitting at different tables and having a lot of informal discussion while things were going on. And, you know, we're trying to mimic this the best we can through this kind of a Zoom exchange. I'm certainly personally open to staying on a few extra minutes, and it sounds like a number of the residents are willing to do that. But as I mentioned a few minutes ago, earlier today we had a research committee meeting, and I met with Doug and Laureen and Val, and we had sort of anticipated that it might be a bit challenging to have this kind of the interaction, and we thought that rather than, you know, having something that goes, you know, a bit too long in the evening and, you know, people get tired and so on, that we might have another opportunity to have some kind of some informal discussions and some one-on-ones. And so we'll plan that out and kind of I think a little bit around that. Could I perhaps just see through the chat line, does anyone have any burning questions right now? And if so, I think we have many people that are open to staying, and if not, if people, you know, because we've been on a little bit over 2 hours, if people want to call it an evening, certainly would understand that as well, and we'll have a separate evening for some informal discussion. So
Michael, can I make one point? This is Natalie Coburn, because people started talking about funding. One thing that I've learned as a supervisor that I think is really important is the idea to apply for funding right now before you get into the program, because a lot of the funding opportunities specify you need to do it for 2 years. And if you need to do it for 2 years, once you get started next year, you're out of the running. So, so if you are thinking about applying, now is the time to actually still start thinking about the funding as well, just because of the way that most of the competitions are written.
That's a really good point. And we actually have an evening session devoted toward funding and grant writing, which will be in the spring, and it remains to be seen whether it'll be done virtually or in person or through some kind of hybrid approach, but we will certainly do that. But Dr. Coburn's comments are quite valid, and one of the skill sets to learn in the surgeon scientist training program is how to write successful grant applications, and you know, there are many benefits to bringing in a research support. So one is that it is considered a major honor for yourselves. So it really distinguishes yourself when someone is reviewing your curriculum vitae. Secondly, it's of great assistance to your research lab program, and also then, you know, to the department as well, as I pointed out earlier in my PowerPoint, just kind of around the financials. And I shared this with you, you know, from the perspective of transparency. You know, where the money doesn't appear magically, and you know, it's kind of a collective responsibility for you know, for all of us. Okay, so I think I'm going to take a chair's prerogative. I don't see any questions arising in the chat line, and I think then I want to thank all of the faculty and all of the speakers for excellent presentations. It was a very comprehensive discussion. It does not reflect everything that we do. My apologies to anyone's research or program that was omitted. We did try very hard to be as comprehensive and as brief as possible. And as indicated, we will have a follow-up, and Doug and Lorene and Val will need to get our thinking caps on and think a little bit about how we will plan this out. We might want to send around a survey to figure out kind of where the questions are that people you know, people would have. But it's kind of been in our experience that the questions and answers are sometimes a little bit better facilitated through small group discussions. Okay, and a big thanks to you, Val, for organizing all of this, and for showing lots of resilience during this rather challenging period. Okay, thank you, everyone. Greatly appreciated. Have a good evening. Take care.
Thank you.